All right, thank you everyone for coming today. I'm just going to reiterate a couple of things and go through some drug costs and what we're doing in the hospital here to curtail having more incidences of C-Diff. So we can't get away from antibiotics. We need them. We have to cure infections. That's one of the reasons why patients do come to our facility, and so we can't get away from that, but they come with inherent risk. Which antibiotics are they all the same? And that's what I really wanted to touch base here was, okay. So which ones are worse? What antibiotics are worse? And I looked at a meta-analysis. Basically, the study looked at 5 observational studies that basically looked at in the community using an antibiotic versus not using an antibiotic and what was the risk of developing C. diff. And what they did is they calculated odds ratios. Odds ratios basically saying what is the likelihood of developing something versus not developing something. And what they found is the highest risk was clindamycin, an odd ratio of close to 17. So basically reading that is patient is 17 times more likely to get C. diff with clindamycin versus not getting any antibiotics. The next ones were fluoroquinolones, so Levaquin, moxifloxacin, Dr. Kadim touched on that. The cephalosporins are mostly 3rd and 4th generations. Monobactam is aztreonam. We don't really use that often unless we have a pen-allergic patient. And carbapenem. So they kind of grouped all of those together and an odds ratio of 6, basically stating that you're 6 times more likely to develop C. diff infection if you had the antibiotic versus not. The ones that have the least, macrolides. Macrolides is a class of antibiotic. Azithromycin falls into that, so Z-Pak. Trimethoprim sulfa is your Septra DS, used a lot. An odds ratio of 1.8. Penicillins. In this analysis, the authors concluded that there was no C. diff with tetracyclines, no C. diff risk with tetracyclines. And then I got this from a review article, again, reiterating what the meta-analysis showed, the ones that are most at risk here. Fluoroquinolones, clindamycin, broad-spectrum cephalosporin, so 3rd and 4th generations, and broad-spectrum antibiotics, Zosyn. So that's everybody in our hospital, basically. So we have to see what can we do to utilize those most optimally and efficiently and with due diligence. The occasionally associated with macrolides, your Z-Pak, your Septra, and the ones that are rarely associated, aminoglycosides like gentamicin, which we rarely use. The use of aminoglycosides have gone to the wayside because of issues with the ototoxicity and nephrotoxicity. Tetracyclines basically have no risk. And flagyl vancomycin, well, we treat C. diff with flagyl vancomycin, and that's why it's rarely associated with it. So it's not only it's not only antibiotics that are associated with C. diff. There are other risk factors. So the idea with patients that develop C. diff, the first thing you have to do is actually stop the agent. And a lot of the times we cannot stop the agent because we have an underlying infection we do still have to treat. But again, this is reiterating what Dr. Kadim said, increased age, underlying diseases also increase your risk. Presence of an NG tube, PPIs and H2 blockers. Everybody that comes into our hospital, if you're on a steroid, if you are have any comorbid conditions where you're being treated in a stressful situation, you have to be on stress ulcer prophylaxis. So a lot of our patients are on Protonics, a lot of our patients are on H2 blockers. That's been associated. Duration of hospital stay also increases your risk. How long is your antibiotic course, and the multiple use of multiple antibiotics. So Rocephin and Levaquin. If you have a vented patient in ICU with double coverage for Pseudomonas, that's 3 antibiotics. So at one point, where can we go and use less narrow spectrum antibiotics so that we can diminish the risk of developing C. diff? Proximity of a CDI patient is one of the biggest risk factors, and so reiterating the fact that hand washing and gowning and respecting the contact precaution signs in patient's room is extremely crucial. And then recent admission within the last 3 months. So if you've had antibiotics in the last 3 months, or you've been in the facility in the last 3 months, also increases your risk. So what are we doing in our facility now? What can we do in our facility to help make sure that we diligently use our antibiotics? And one of the big push in most of the facilities, and this is supported by various organizations, the IDSA, the American Society of Epidemiology, and Pediatrics Group, basically that all facilities should move towards having a antimicrobial stewardship program. And the idea with that is that they came up with a consensus statement saying it's coordinated interventions designed to improve and measure appropriate use of agents, promoting selection of optimal drug regimens, including dosing, duration of therapy, and route of administration. The coordinated intervention is the key word, and that's basically prospectively looking at use day to day and seeing where there are opportunities for improvement. And a lot of these programs are run by ID specialists, infectious disease specialists, docs. So the team is headed by usually an infectious disease physician, ideally with additional training in antimicrobial stewardship. There's a clinical pharmacist that's part of the staff, as well as an infection control nurse. I participated in this in Connecticut. I spent about 8 months doing it with basically a group of ID physicians. And what we were doing is following all patients on broad spectrum, mostly carbapenems and Zosyn throughout the facility, and then putting in interventions, basically suggestions as to how they can narrow the spectrum or discontinue therapy. The benefits of the program: it's proven to improve patient outcomes, reduce adverse events in C. diff, improvement in rate of antibiotic susceptibility to targeted antibiotics, and optimization of resource utilization. That website is from the CDC. The CDC supports all of this. On this website, they have evidence supporting the use of antimicrobial stewardship to curtail C. diff incidences in various facilities. So this is a big, big push for this. What are we doing here? We don't have a ID physician on staff, so there are things that we can do and we are doing to try to make sure that we are optimizing our antibiotics. So I just wanted to quickly go through those. All of our antibiotics, antifungals, antivirals, have a 7-day limit to them. At the end of 7 days, our providers get a phone call from us, and some of them are here, and we call them and say, it's been 7 days, do you want to stop, continue, do we need to continue? We do a yearly antibiogram. That's basically looking at how many isolates our microbiology lab in our area has isolated and what their susceptibility is to our antibiotics. That can target our empiric. What do we use empirically? We run, the pharmacy department runs a infectious disease microbiology report. So on a daily basis, we try to follow cultures. If there's cultures that have come out that morning that say, hey, this patient has an E. coli infection, can we change the antibiotic? Or looking for areas of opportunity to target. A renal report is basically anything that is renally cleared. So things like Levaquin, you don't want to have a 83-year-old lady with a creatinine of 2 getting Levaquin 750. So that is a phone call that we would make to our providers, see if we could get that dose reduced or get it switched. A vancomycin dosing protocol, aminoglycoside dosing protocol. We review all pre-op antibiotics, so to make sure that we're not using carbapenems or Zosyn preoperatively as a one-time dose. So it has to be a narrow spectrum just to cover mostly skin flora. So that's why we use ANSEF in most cases. Diagnosis-based order sets. That's basically to aid in appropriate selection to provide coverage for certain diagnoses. So we have one for pneumonias and diabetic foot infections and things like that. And then to limit the use of broad spectrum antibiotics, we actually do a pretty good job in not using a lot of carbapenems in our facility. And our antibiogram shows that we have like 5 to 10 ESBLs, extended spectrum gram negatives, a year. So that's in the grand scheme of having 1,500 E. coli's a year, that's actually pretty good. And that's because we are not using these broad spectrum antibiotics. So the last thing I want to touch on is treatment costs. This is specifically for outpatient setting. If you are going to send somebody on with a prescription for vancomycin, Vancomycin was the only brand available up till a few years ago. Vancomycin, each capsule of 125 milligrams was $94. So the treatment for 10 days is in the thousands. There is a generic capsules, that's a third of the cost now. That came out recently. So those prescriptions there, most of the pharmacies will not carry this. Insurance companies will not carry this on the shelf. Most insurance companies will require a prior authorization. And it's always good to call the pharmacy department to make sure, or local pharmacies to see if they have it on the shelf or not. Fidaxomicin Difficile is $220 tablet. The actual cost to the pharmacy would be $3,000. So you're looking at $4,000 for a 10-day treatment. If it had to be paid in cash, that's self-paying. In the hospital, we basically use the vancomycin vial and individualize the doses for 125 with sterile water, 125 or 250, and it's a 14-day expiration date. The vancomycin via enema, the dose would be 250 to 500. In 100 mLs of sterile water every 6 hours. And that's not orderable right now in OM. The only person I could foresee ordering that would be Dr. Kadim. So, and that it would probably be going to the OR, so OR or to the floors. So if that needs to be ordered, if we ever run into a case that we need to do that, a call to the pharmacy needs to be made, and we would enter that through our end so that it could be documented on. The last point is this year, just this past year, there's a new oral suspension that has come out. It's called 5-Vanc. The bottle is about $100, and it's a great flavored. It's good for 14 days. You refrigerate it. So this just got approved this year. So I don't know if anybody's familiar with this, but it is a fraction of the cost of the oral tablets. And that's basically it. I just wanted to touch base on those points. Thank you.